Good morning, everyone. Today I'll be discussing my presentation on medulloepitheliomas masquerading as panophthalmitis in an unusual presentation. As we know, intraocular medulloepitheliomas are the congenital tumor presenting in first decade of the life, arising from primitive medullary epithelium, presenting either white, gray, or yellow-colored ciliary body tumor. Rarely, these tumor can arise from optic nerve or retina. These tumor may show extensive invasion with extraocular involvement, requiring exenteration, requiring either chemo or radiotherapy later on. But information on long-term survival rate is limited due to rarity. Reports on these tumors presenting as orbital cellulitis and panophthalmitis are sparse. So here in coming slide, I would like to describe the difficulty we faced in diagnosing and managing the patient who presented to us with this tumor in a young pregnant female. So a 29-year-old pregnant female at 26 weeks of gestation presented to us with the chief complaints of pain and redness since 15 days, which was followed by progressive protrusion of the right eye since 10 days. Patient took treatment from the government hospital but did not improve, and patient also had a history of post-traumatic loss of vision in the right eye 5 years back. On ocular examination, right eye had no perception of light and left eye had 6/6 vision. On adnexal examination, upper and lower lid swelling was present, which was associated with matted lashes and yellowish discharge. There was a prominent axial proptosis in the right eye. However, bulbar conjunctiva was chemosed and hemorrhagic, showing dilated and tortuous episcleral venous vessels. Cornea was lusterless and corneal opacity of 6 mm into 5 mm dimension was present. However, anterior segment details and posterior segment details were obscured in the right eye, and left eye was within normal limit. All the extraocular movements were restricted in all the gazes in the right eye. On doing ultrasonography, B-scan, multiple point-like echoes in the whole of the vitreous cavity, which was suggested of exudate, was seen in the right eye. So working diagnosis of right eye panophthalmitis was made. Patient was admitted and systemic workup was done, which came out to be unremarkable. And patient was managed on IV antibiotics and topical medications. Contrast enhanced MRI scan of orbit and brain was done, which was suggestive of mixed intensity mass filling the right lobe, extending into the intraconal and extraconal spaces with infiltration into the preseptal space. As we can see, then in all the section, there was complete loss of globe architecture. So as the patient was pregnant, we could not do any surgical procedure, and patient was not improving on conservative management. So we went ahead with the other modalities like USG guided FNAC was done, which came out to be suggestive of malignant small round cell tumor. So metastasis was ruled out, and to further confirm our diagnosis, excision or incisional biopsy was done, and which again suggested that our patient was suffering from malignant small round cell tumor. After taking gynecological and radiotherapy opinion, she was planned as follow, that surgical debulking was done as early as possible, and patient was planned for earliest delivery at 34 weeks, and later on she was planned for chemo plus minus radiotherapy. So after doing surgical debulking procedure, patient had uneventful postoperative period, and on gross specimen we could see the optic nerve involvement by the tumor. Histopathology revealed that patient was suffering from right eye orbital imaging-teratoma. So after that, patient was induction of labor was done at 34 weeks of gestation, and patient was followed in IOPD for wound dressing, and patient had uneventful period. After ruling out metastasis and staging of tumor was done, and first cycle of chemotherapy was started in the form of cisplatin, bleomycin, and topside. After giving 3 cycles of chemotherapy at 21 days interval. So keeping high suspicion of other tumors in and atypical presentation of orbital teratoma in this adult patient, we requested for repeat histopathological examination. So what came to our diagnosis, that patient was actually suffering from right eye orbital medulloepithelioma, which was malignant teratoid type. So patient shifted from chemotherapy to radiotherapy. So coming on to discussion, as we know, the malignant teratoid medulloepithelioma is an extremely rare embryonal tumor of neuroepithelial origin. Patients diagnosed later in life are thought to be malignant transformation of their benign counterpart. So mainly these type of tumors consist of heteroplastic elements consisting of small round cell neuroblast indistinguishable from retinoblastoma. Initial misdiagnosis and delay in treatment are not uncommon in the absence of classical features. So timely diagnosis and vigilant approach have a key role in preventing inadvertent adverse outcome in these kind of patients.